Welcome to All Things Cardio-Oncology. My name is Steve Caselli. I'm the Executive Director of ICOS. And in this podcast, you'll hear from a diverse representation from our community. We want you to be both informed and inspired by their stories and experiences, and we're so glad that you've joined us today. We're glad to be back again for another episode, and in this episode, it's a pleasure again to welcome my co-host, Dr. Arjun Ghosh. Arjun, you want to say hello and introduce yourself?
Hi, thanks a lot, Steve. My name is Arjun Ghosh. I'm a consultant cardiologist at Barts Heart Centre and University College London Hospital. Really looking forward to this episode to learn more about this new term that's introduced into the cardio-oncology lexicon.
Excellent. We'll hold off on what that term is, but just say hello to Dr. Charlie Porter. Dr. Porter is well known in our cardio-oncology community. He established the cardio-oncology program at the University of Kansas Medical Center. Charlie, you want to say hello?
Hello, everyone around the world, whatever time zone you're in, which could be one of about 24, I think, with the coverage we have now of ICOS.
I think that's about right. Well, recently, Dr. Porter published an article in the JACC Cardio-Oncology Journal, September of 2022, and the title of that article was Permissive Cardiotoxicity, the Clinical Crucible of Cardio-Oncology. So to begin, Charlie, I wonder if you could just tell us, what is permissive cardiotoxicity?
Well, thanks for having me on. I'm really pleased to see that someone actually read the paper and is interested in talking about it more. That's always encouraging. I think permissive cardiotoxicity is a new concept that I think represents pretty much the polar opposite of a more primordial idea of prohibitive cardiotoxicity, which started in the anthracycline era, where the cardiologists just carried a big stick, and if they saw any cancer drug causing any form of cardiotoxicity, they just beat the drug with a stick and told the oncologist to go do something else because the heart was abnormal, and that was impermissible. And permissive cardiotoxicity is the idea that toxicity is affecting the heart, often LV dysfunction, but hypertension and other things are not precipitous events like a plaque rupture that leads to an acute myocardial infarction, but a degree of progressive abnormality that can be identified and monitored and have the effects blunted with close observation and prudent management of the toxicity, while trying to continue the management of the cancer in the best possible way to produce a cure or prolonged survival.
So if I'm understanding you correctly, this is the allowance for a certain degree of toxicity in order to continue the best cancer therapy. And I wonder, is this a term that you came up with, and how did you come up with this idea? Well,
it's hard to know if you first came up with an idea. But my wife, I was talking to my wife about doing this podcast, and she said, "Oh yeah, I remember you came up from your office one night and said, hey, I told her that I just thought up this concept, permissive cardiotoxicity, but I didn't really know whether I had gotten it from somebody else and adopted it, or it actually just clanged into my head." And I was at a AHA cardio-oncology science Zoom meeting with, Susan Dent, Javed Moslehi, Vlad Zaha, Tokyo Kuosa, Tochi, and I presented the term to them, and nobody seemed to have heard of it. So I thought, if they don't know about it, it's new. And that was several years ago, and thus far nobody else has come up to me or emailed me or gaslighted me on Twitter that I stole the idea from them. So I guess I did just think of it when I'm sitting in this chair in my home office where I'm talking now.
Well, that's fantastic. It seems like a logical, very useful concept. Arjun, what do you think about that?
Yeah, I think it's a very interesting concept. I think that it is something that we probably all practice within cardio-oncology, but maybe, the term hadn't been crystallized. And for sure, I think Charlie does have the copyright, because I can't recall hearing the term permissive cardiotoxicity before it came out in the paper. So I think, kudos to Charlie and his co-authors for, getting it out there as a kind of accepted part of the lexicon. So I think, one of the questions, I guess, from a practical side that I'd like to ask Charlie is that, given that, as Steve mentioned, that sometimes, we might need to accept a degree of cardiotoxicity. Does that mean, Charlie, that you would advocate that we start or carry on with cancer treatment without waiting to get, good levels of cardio protection on board? Or, how does this work in practice?
Well, unfortunately, for us in the field, you cannot take things like post-MI or post-revascularization LV dysfunction and take 3 months to apply guideline-directed therapy to see if someone needs an ICD or qualifies for an ICD with sustained LV dysfunction. Because cancer doesn't wait. It's got nothing to do 24/7. Never has holidays. All it does is, exercise its properties of uncontrolled cell growth, local invasion, and metastasis. And you need to start soon. I mean, one of the cases that I dealt with early was a woman who came to me on a Tuesday. She'd been found 2 days into the prior week to have lymphoma as the explanation for her little lump under her collarbone. And her left carotid was encircled by the tumor. And the oncologist wanted to start treatment with anthracycline 2 days later. And I was not as involved with dexrazoxane then as I am now in that kind of situation. But she was young. She had few risk factors for anthracycline cardiotoxicity. And I just told her, I think this is a curative tumor. Your life and the lives of your 3 children under 10 all depend on this. And we can launch into this. And her EF was like 40% by 2 different modalities. And there's not much guidance. There's now more approval on guidelines of starting therapy, but there's not a lot of guidance. And particularly, several years ago, about starting anthracyclines with EF hovering around 40. But I just said, well, I talked to her. I talked to the oncologist. Her mother was a cardiothoracic surgeon, and I got her on the call, and she understood risk-benefit ratio of allowing the tumor to advance around her daughter's carotid or take a chance on anthracycline. So that's what we did. I followed her closely. We got carvedilol. When you don't have heart failure, it's easier to advance beta blockers rapidly when you're dealing with stage B than advanced stage C heart failure. There's no congestion. Most of these cases, you're seeing what's stage B heart failure, asymptomatic LV dysfunction, and particularly if someone's hypertensive, you can rapidly advance the drugs in an accelerated manner and start the therapy for the cancer at the same time. And that's why I call this the clinical crucible, because the crucible is the area where you're really creating a therapy. It's the center of treatment. And that is, I think, different in cardio-oncology from assessing a risk profile or seeing someone post-therapy and you're assessing risks related to prior therapies. Those things are not as compelling. They're not as time dependent, and you're not altering the outcome rapidly within a period of days or weeks as you decide to initiate full therapy or not, or use an inferior therapy that may have less cardiotoxicity potential. So that's really one of those things where I tell the patients, I'm a little uncomfortable in advancing this, but I'm more uncomfortable in telling your oncologist that you have to go with plan B. So it's a two-edged, or maybe there's more than just two edges on the sword, but it's challenging, and they get everyone in those visits, they get your full attention.
Yeah, I think you've really just brought out how we often have to go for an individualized approach in cardio-oncology, and no two patients are the same, and there are quite a number of nuances in all of these patients. And I was talking to a colleague of mine who's not a cardio-oncologist who came across this the paper that you wrote, and one of her comments was, does kind of permissive cardiotoxicity mean that we should be just allowing or accepting a certain degree of risk, or does it mean that we should be monitoring these patients a bit more closely? So she's somebody who was aware of the recent ESC ICOS guidelines, but hadn't necessarily read them in detail. And I think, of course, one of our aims is to educate, all cardiologists, all oncologists. So I don't know, Charlie, what you think about that comment. And I think it's quite relevant maybe to the case that you just mentioned.
Well, it's kind of a blend of those, and I think the new ICOS or ACC ESC guidelines published recently do leave a lot of pathways to continue treatment without a clear description of how to walk along that path. And I think if you're comfortable with the idea of permissive cardiotoxicity, you can decide this is kind of it's the enunciation of how you get from the guidelines, which say may be considered. Well, if you are already, and people in cardio-oncology have been doing this, like you have been doing this for a while, perhaps not recognizing that there's a rubric, there's a what banner you're walking under. But I think the whole concept of permissive cardiotoxicity and the guidelines increasing endorsement of finding a way to continue therapy. And I think in all these areas where the numbers are small, the drugs are new, waiting for guidelines to tell you what to do is not going to work. I find guidelines helpful if you've got a lot of data. You can connect data points and make a big dark line connecting all these points and say, this is what you can do. But we're extending, we're beyond the tip of the spear. These are new, perhaps a new drug with a new toxicity. And you have to find your way to find a path to apply what you have seen in other drugs. And in working with the oncologist and the patient, say, we're going to move forward with this. I just saw last week, I just saw a patient who had positive troponin on a phase 1 trial drug that is one of these neurotropic kinase receptor blockers. And there was nothing in the investigator brochure about cardiotoxicity. And so I went back and found 2 other drugs in that class that are FDA approved. And one of them, entrectinib, had a 3% incidence of heart failure and a 0.3% incidence of myocarditis. So right now we're trying to sort out the myocarditis, but we're just dealing with new drugs, that may come out. Margetuximab was approved for metastatic breast cancer, HER2. And the trials are 800,000 people to start and 200 to finish. It's not at all like looking at Paradigm HF or Entresto. 8,000 patients in the trial. No surprises about what that drug's going to do. But you have to, every little creak in the floorboard could be a crack in the foundation with these new drugs. You just have to be alert, but maintain focus on the fact that these new drugs are approved for lethal cancers.
If you or your institution would like to have credentials that confirm your qualifications as a cardio-oncologist or a cardio-oncology center of excellence, we encourage you to consider applying for our certification exam in cardio-oncology or our certification for centers of excellence. These are the only certifications currently available in this field, and it's a special opportunity for you or your institution to distinguish yourself recognizing your expertise in the field. More information about both these opportunities can be found at ic-os.org, or you can email directoricos@gmail.com for more information.
Yeah, I think you raise a really, really interesting point, because if you think of, obviously, one of the drugs we're more aware of, the checkpoint inhibitor myocarditis, how important is the troponin rise? Is it going to actually be severe LV dysfunction? Will it be fatal? Will it not? So I think that's a really important concept. And you touch upon this in your paper as well, because you talk about drugs with a safe harbor zone. And I think that, as we've talked about, it can be maybe difficult to define and can be unpredictable. And as you mentioned, what about new drugs? There's so many new drugs on the market, immunotherapies, especially nowadays. I mean, how would you approach something like that? I mean, as you mentioned, this, it's a phase 1 trial, and how can we get to this safe harbor for these newer drugs?
Well, I think it's very difficult, and that's really fascinating to be seeing someone where the global experience is in a handful of patients, and these are not drugs being tried for rosacea. So there's high stakes if they don't continue. These are all drugs where there's no really good alternative. And I think the safe harbor, you just have to, and I think a principle that I can't fully prove, but I think would be valid. I wouldn't want to go up against, in a debate, but I think we are seeing very few drugs that have a precipitous onset of a catastrophic event. Most of the time, these things are graded. There's probably a graded toxicity, and the anthracyclines. I still see young people who show up in pulmonary edema after a fairly routine, low-risk administration of anthracyclines, but for some reason, that genetic profiling that we don't do routinely, they are vulnerable, and that's catastrophic. They're in the ICU and they've got pulmonary edema and their EF's 15. But for the most part, these drugs are not causing, particularly the newer targeted therapies, are not causing a fulminant problem. Some things like dasatinib with its pulmonary hypertension seems to present fairly precipitously, but pulmonary hypertension is a very challenging diagnosis or condition to detect early. No one that I've seen is doing routine echo Doppler monitoring pulmonary hypertension, PA pressures, and dasatinib. That might actually be a way of identifying that early when the PA pressure has risen from 30 to 42 before it shows up at 90. Because it's probably there. I don't think people are going to bed with a PA pressure of 30 and waking up with one of 90, but it's the revelation of that is sudden when something goes wrong enough to check. So I think that a lot of these drugs, it depends on your threshold for surveillance. And the new guidelines, if anything, the ESC guidelines, I think, call for more surveillance troponins than we can handle. And a good example of that was Ron Watellis and the Stanford team drew troponins on everyone getting checkpoint inhibitors. And the specificity for myocarditis was rather low. And they had basically a rapid response team who during the protocol were assigned to go to that patient and evaluate them immediately. And that's not practical. I mean, I don't think you would want to be identified to deal with every troponin that goes above 0.01 in your institution who's getting a checkpoint inhibitor. You'd be sleep deprived and be cranky.
Yeah, I think
it's tough to know how much knowledge is enough.
Yeah,
there's a study in renal cell cancer that I've seen where they just sampled everybody with troponins. They had about a 5 or 8% incidence of unexplained abnormal troponins just in association with cancer. Renal. Yeah. So, trying to look at all that stuff, it's to a certain degree, ignorance might be bliss on some of these things. Wait till the signal's a little stronger.
Exactly. I mean, I think it's difficult, and sometimes we don't know what to do with all this information. I was in clinic this week with a senior trainee who basically asked me that if we were to check the troponin in a patient who was giving checkpoint inhibitors, as soon as it's raised, what do we do? Do we bring them in? Do we treat them with steroids? Do they become an inpatient? So exactly the points that you raised. And I think it comes back to maybe that thing you were talking about in terms of, millimeters of mercury, pulmonary artery pressures. You talk about allowing a degree of, cardiotoxicity. What do you think, Charlie? Should this degree of cardiotoxicity be defined? Would that make it easier, or would that make it more difficult, i.e., allow a certain degree, this is the cutoff, above that you must do something? Would that make our job harder or easier if something like that was in the guidelines?
Well, for me, being a natural contrarian, I don't think that whatever the rule was, there would still be reasons why I would go beyond it. And I think
right.
Because when you're trying to get into guidelines, particularly if you're doing a guideline according to standards that are set for common conditions with large clinical trials like coronary artery disease or heart failure, and then you're trying to apply them to situations where the cohorts are smaller, the experience with the drugs are different, and there are different types of drugs. I don't know that you can do that or will ever be able to do that. And I think part of it is just based on a balance. For me, it's a balance between working with the oncologist to find out what are the stakes, what's wrong with this, and the oncologists know about that. I had a patient who had gone through all the anti-HER2 drugs fairly well, but her disease had progressed, and she had disease progression in HER2, and I was cautiously, I was bracing myself to try to continue therapy, and he said, "I'll just switch her to sacituzumab. It's a new dual action drug that acts on this trophoblastic protein and TROP2, and there's an alternative I didn't know about. But some of these alternatives will allow you to not have to push, and you have to work with the oncologist to find out what the degree of pressure there is on the oncologist to stay with that drug or go to an alternative. So you're never alone. And I've found very few patients when you're dealing particularly with curative intent cancer, where you're offering them the situation about having the cancer progress, but being happy that your ejection fraction is normal. To me, it's sometimes people don't want to they don't want to pay for a novel anticoagulant because it costs too much or something, or they don't like taking a drug twice a day. And I just tell them, well, I think you'll like taking that drug twice a day better than you will stroke rehab, but it's up to you. And I think some of these other things, you work with the patient, you work with the oncologist, and it's kind of it's a triangulated collaborative decision making, and you can't do it by yourself in this situation. You don't want to.
Yeah, and I think that's the ideal kind of happy medium for cardio-oncology, isn't it? Collaboration between cardiologist, oncologist, and of course, with the patient in the center. And coming, I guess, to the end of my question, something that you kind of put towards the end of your paper. You've mentioned this already about changing mindsets of oncologists, and we've often had, and I think so from my personal experience, this has actually changed while I've been involved in cardio-oncology. I remember towards the beginning of my entry as a trainee, oncologists would often stop treatment without even consulting cardiologists and saying that this cardiotoxicity, I'll go for another drug, or I'll just stop, or something along those lines. Then cardio-oncology came in. Oncologists realized that there were some friendly cardiologists whose job was not to stop treatment, but to try and facilitate treatment. And they became a bit more willing to discuss and carry on and allow for certain, abnormalities and toxicities. But I think that may be restricted to those, cardiologists who have an experience in cardio-oncology or who are interested in that. And of course, there are still, many oncologists who refer these patients to the local cardiologists who may not be so, au fait with all the branches of, cardio-toxicity and what to do. And you talk in your paper about changing the mindset of oncologists to, should this therapy be discontinued, to how can we safely continue this therapy? But I put it to you, Charlie, what about changing the mindset of, general cardiologists who still actually have a big part to play in managing these patients?
Well, that's a terrific question, and it's a challenge. But I think that it depends on the breadth of vision of the cardiologist, because when I started out, it's been a while. The first those back-to-back papers on trastuzumab in early stage breast cancer were published in 2005, along with the incidence of heart failure that kind of triggered my interest in this. But I think we're kind of closing the door on the era when cardiologists will say, "Oh, we all see cancer patients. Why do what's a cardio-oncologist? It's just some guy who doesn't do procedures. They're not doing TAVRs, so they got to act like they've got something special to offer, But I think just amongst my own colleagues, I've got like 40, I can't keep track, 40 cardiologists, but they are increasingly calling and just saying, hey, what do you think about this? I'm doing this. And it's not an age related thing, the fellows, but I think there's just an awareness that these drugs are odd. They don't know them. It's not just adriamycin. Adriamycin really, that's kind of easy. That's just cardiotoxicity, they know they can put a vat in them and transplant them if they get that far. And, that's cardio-oncology. And, if you're doing a valve replacement on somebody with radiation, it's going to be a tough dissection. But I think people are learning that these things are more and more specialized, and they're just happier to collaborate either by a phone call or direct referral. But I think there's a lot more conversations underway, and that's where it starts. Really, is awareness and learning what they don't know, but I think it's a process, but it's underway. I think it's underway.
I think this paper makes a terrific positive contribution to the field. I think in the oncology space, but as you're saying, in the cardiology space as well, there's still that fear of this is a negative discipline of interrupting therapies when in fact it's quite the opposite. And I think your paper really pushes that. So Charlie, thank you for this wonderful work. And I do hope that part of this podcast will get some more readership for it. We'll definitely put links in the show notes to it. So thank you so much.
Thanks, Steve. Thanks, Arjun. And I just heard yesterday that the planners of JACC in Madrid in September are going to have at least a little segment on permissive cardiotoxicity. So
yep.
If you want to learn more, come to Madrid.
Arjun, thanks again for your time.
Thanks so much.
Thanks, Arjun.
For more information about ICOS, you can go to ic-os.org, where you'll find more information about all of our programs, including our weekly webinars, our board certification exam, and other resources that we know you'll find helpful. Thanks for joining us today, and we hope to hear from you soon.